Kia ora everyone, and welcome to a lecture on ultrasound-guided peripheral IV insertion utilizing a transverse approach. The target audience for this lecture will be twofold. It will be for those healthcare providers with minimal ultrasound experience who are already adept at inserting peripheral IVs, but it will also be for those that have already garnered a lot of experience performing ultrasound-guided IVs but are looking to increase their success rates. Particularly the second half of this lecture will be useful for those that already have a good amount of ultrasound experience. Just a few expectations before we get into it. Number one is that ultrasound is not a replacement for standard IV insertion. There will inevitably be scenarios in which a difficult to cannulate patient arrive in critical condition and require quick IV access that is best obtained with standard IV insertion. So I strongly encourage you to not automatically default to the ultrasound for a difficult to cannulate patient and to continue working on your skills on obtaining standard IV access in these patients. Number two is that this is not a lecture on ultrasound. While we will cover a few basic principles so that you know how to use the ultrasound to perform this procedure, we will not bog you down with any unnecessary details. And finally, advanced techniques will not be covered. With good evidence to support us, it has been shown that the transverse approach is really all you need to obtain an IV utilizing the ultrasound. While techniques such as needle profiling, longitudinal approaches, color Doppler, etc. can be used to help obtain IV access, they are very rarely necessary and will not increase your success rate using the ultrasound nearly as much as understanding the principles in this lecture. This lecture will be broken down into 4 main parts. We will briefly cover a few core principles that you will need to know to perform this procedure. We will then develop an approach to identify a good target vein for IV cannulation. We will cover the procedure itself, and then conclude with just a few final thoughts. On to the ultrasound core principles. We will briefly cover the 3 main probe types, go over the probe features that you will be required to know to perform this procedure, review some basic anatomical terminology, and finally go over the cardinal movements that you will need to know when attempting IV access with the ultrasound. Pictured here are the 3 main probe types. If you look at the right-sided images, we'll see the part of the ultrasound probe that makes contact with the skin, and this is known as the footprint. What you will also notice is that the footprint for the linear probe is flat and straight, whereas the footprints for the curvilinear and phased array probes have at least some curvature to them. And what this means is that the ultrasound waves coming from the linear probe go straight down and come straight back in. So what you see on the ultrasound screen is exactly what you get, and it's for this reason that we will really only concern ourselves with a linear probe for this lecture. Moving on to a few essential probe features. On each ultrasound probe, you will notice a small bump on the side, which corresponds to the dot on the ultrasound screen. This is known as the probe indicator, and you always want the probe indicator to face to the left as it does on the screen, so you will be properly oriented. The next feature to pay attention to is the center line. So you could see that on the center of our linear probe, there's the straight line, which indicates the middle of the probe. And what I'll show you later in the lecture is how to activate the center line, which will appear as a dotted line on the screen and corresponds to the center line on the probe. And finally, the last feature I want you to be aware of is the depth measurement on the side. You can see it runs from 0 to 4, and this is in centimeters. So if we get to 1, this means that you're 1 centimeter below the skin surface. Now note, you can change the depth, but to me this is an advanced technique that you do not need to use to perform peripheral guided IV insertion. Next up, we will quickly review a few anatomical terms. There are 2 planes that we can use when performing ultrasound guided IVs. The plane that we will be utilizing is known as the transverse plane, which simply means that the probe footprint is perpendicular to the vessel that we are looking at. So it takes a cross section of that vessel, and the blood vessel looks like a circle on our ultrasound screen. The second plane is known as the longitudinal plane, and if we make our probe footprint parallel to the vessel, we can see the vessel on its long axis, which you can see here on the ultrasound screen. When we move the ultrasound probe around a patient's arm, we need to be sure that we're utilizing the same terminology so we all understand the movements that are being performed. As a quick review, we have the medial aspect, which is the part of the patient's arm closest to their body, the lateral aspect, which is the part of the arm away from the body. We can move proximally up the arm towards the head and the torso, and we could also move the probe distally, which is towards the hands. And finally, there are 3 cardinal movements that you will need to know. These are known as sliding, fanning, and rotating. We can slide in 2 main directions. One is horizontally in a medial to lateral direction, and the other is vertically in a proximal to distal direction. Similarly to our vertical sliding, we can also perform fanning, which allows us to look both proximally and distally. This is easily performed by keeping the probe in its location and tilting it both proximally and distally. Our final cardinal movement is known as rotating, and it is exactly as it sounds. You can either rotate the probe in a clockwise or counterclockwise direction. Now that we've covered a few core principles, let's move on to the second part of this lecture, which will help us decide which vessel to target for cannulation. There are 4 main considerations when choosing a target vessel. Number 1 is to apply the knowledge that you already have when attempting to access veins in the upper extremities. Number 2 is when you are actually using the ultrasound probe, how you can distinguish between a vein or an artery. And numbers 3 and 4 are for when you have identified a vein, how you can determine if it is indeed a good target. Just a review of typical venous anatomy in the upper extremity. Typical good targets for ultrasound-guided peripheral IVs will include the brachial and the basilic veins. The median cubital is often a good target as well, as it crosses in the center of the antecubital fossa. And then there are plenty of proximal forearm veins that are often good targets as well. Of note, while the basilic vein can be a good target, it tends to run deep and also adjacent to nerves and arteries, which can make it quite difficult to access. Now that we know where we will typically find a good target, the next step is to know how to distinguish a vein from an artery when using the ultrasound probe. This is very simply done. In this example, you can see that by applying downward pressure, the vessel on the left-hand side of the screen disappears, while the vessel on the right-hand side of the screen does not compress and even becomes a bit pulsatile. As you know, veins are easily compressible, so the vessel on the left-hand side of the screen is a good target vein, while the vessel on the right-hand side is indeed an artery. So once we have identified a potential target vein, how do we know it will actually be a good vessel to target? Well, the first step is to look at its diameter, depth, and its length. These 2 examples show 2 good target veins. And the reason we know that is that we typically want a blood vessel that is at least 0.3 centimeters deep, but not greater than 1.5 centimeters deep. And we want a diameter of a vessel that is roughly 4 millimeters or wider. Now, there are ways of measuring the diameter of a blood vessel, but to me this is a slightly time-cumbersome and unnecessary step. After just a few attempts with ultrasound-guided IVs, you will have a good sense for if the diameter of a vessel is wide enough to make it a good target. When looking at the length of a vessel, we will simply slide the probe up and down vertically, ensuring that the vessel does not make any sharp twists or turns or have any sudden bifurcations. In this example, you will notice as the probe moves distally, we will see the vein branch, but then as we move proximally, the vessel stays in a nice and straight course. Finally, once we know we have found a good target vessel, we will need to map our target to ensure that it stays in the center of the probe. This can be conceptually difficult to understand, so we will use a real example to show you what this looks like, but then simplify it to enhance your understanding. What we can see here is that as the ultrasound probe is sliding proximally, the vessel on the screen will move to the left. In order to keep the vessel in the center of the screen so that we know that the needle insertion will go in the same trajectory as the vessel, we'll have to rotate our ultrasound probe and then slide again to ensure that the vessel stays in the center of the screen. So in this example, we will use a straw as the vein. When we first slide the ultrasound probe proximally, the straw will move to the left-hand side of the probe, which would correspond to the left-hand side of the screen. We will then rotate the probe counterclockwise so that when we slide vertically, the vessel stays in the center of the screen. And since we insert our needle at the center line of the probe, this means that the needle will be going in line with the blood vessel that we are trying to gain access to. So now if we come back to the example that we had just looked at, we can see that as we slide the ultrasound probe proximally, the vessel moves to the left, but we will simply rotate the probe counterclockwise, slide again, and we will continue to slightly rotate the probe until the blood vessel stays in the center of the screen. You can imagine in a separate example, if the blood vessel moves to the right-hand side of the screen, you would rotate your probe in a clockwise fashion and slide until the vessel stays in the center of the screen. Now that we know how to select our target and map it so it is oriented properly, we can move on to the procedure. It's time to apply the knowledge that we just covered, add a few key principles, and then you will be ready to practice this procedure on your own. We'll break this section down into two main parts. The first part is how you set up the patient in the room, which is crucially important. And then the second part will actually be the insertion of the IV itself. Here we can see a properly positioned room. The tourniquet is nice and high on the arm and away from the field that we are attempting access on. The ultrasound probe is on the opposite side of the bed, which is in line with the direction that the needle is being inserted. And finally, the height of the bed and the head of the bed are at a comfortable height for both the patient and the proceduralist. What often happens, particularly in rooms that are so small that you would have to move the bed to accomplish the setup, is poor setup, which will lead to poor technique. In the new example on the left, we can see that the tourniquet is really far down and in the way. The bed is too low, so the proceduralist has to bend over in an uncomfortable position, and the ultrasound probe is on the same side of the bed that the procedure is being performed. And I promise you, when you have to turn your head to look at the ultrasound machine while inserting a line, it's very difficult to keep the needle going in the trajectory that you want it to go. Once we have the room set up, we can turn the ultrasound machine on and select the settings that we will need to perform this procedure. This is the first screen you will see, and you could scroll under the linear probe to select the venous setting and hit scan. The following screen will look like this, and the only thing that we need to do is simply turn on the center line. Now that we have properly set up our room and the ultrasound machine is ready to go, let's get to the insertion. Ultrasound guided IV insertion is a lot like standard IV insertion with just a few tips and tricks. We've set up our room and mapped our target. We will briefly cover how to properly clean the probe and insertion site. For the actual procedure, you will start by inserting the needle at 45 degrees at the center line. You will then attempt to locate the needle, and I will explain what this means when we get to it. And finally, once you obtain your flash, you will flatten your needle angle similarly to as you would do with a standard IV approach and slowly advance the needle, only this time using the ultrasound to identify and locate the needle as you advance. So again, there is our proper setup, which we already covered. We've mapped our target. We will attempt our insertion just proximal to that branching point of the blood vessel. The blood vessel stays nice and in the center of the screen, so we know our needle will be in the proper trajectory. But before we get to needle insertion, we briefly need to talk about how to clean the probe and the insertion site. While it has been suggested to use sterile ultrasound probe covers, or even covering the ultrasound probe with an adhesive barrier, there's limited evidence that this approach works. So simply giving the ultrasound probe and the cord a good wipe down with a universal wipe and prepping your IV site as you normally would is both safe and more time effective than the alternative approaches. Now that we are ready to insert the IV, we will start by inserting the IV at a 45-degree angle, being sure to insert the needle at the center line of the probe. For this next section, I'd like to clear up what I feel is a main source of anxiety when first learning to perform this procedure. When you first learn to do this, you expect that as soon as you insert the needle under the skin that you'll be able to easily see it with the ultrasound probe, and when you can't see it, sometimes we assume that it's a fault in our own skill, when in actuality, it's just really difficult to find the needle when you're inserting it at 45 degrees. The reason why is that the needle is much easier to visualize when it is perpendicular to the ultrasound probe. So we can imagine that if we are inserting our needle at 45 degrees, that's not quite perpendicular to the ultrasound probe and is often hard, if not impossible, to see. However, later on in the procedure, when we flatten our needle, that's when it will light up and be much easier to see. So the question is, what do we do? And what I will offer for you here are a few troubleshooting tips. Number one is what I call trust the process. We have carefully mapped our vessel. It's at the center line. Our needle is being inserted at the center line on the ultrasound probe, so we know we are directly above it. And when we watch this example, what you'll notice is that if you look on the left-hand side of the screen, we never actually see the needle itself. But if we look at the right hand of the screen, we can actually see the IV begin to flash. Particularly for the deeper vessels, it can be important to ensure that you are directly above the center of the vessel. Another technique we can use to try to identify the needle is to simply bounce the needle with our right hand, and you could see that the bouncing occurs just above the center of the blood vessel. We could also use a technique which I call fanning back, which I'll briefly show here, but then we'll simplify with a cartoon. Essentially, the goal of this technique is to make the needle more perpendicular to the probe. So you can imagine if we advance the probe slightly and then fan back, we can make the needle more perpendicular to the probe, which will increase our chances of visualizing the needle. And finally, while I did not think to make a real-world example of this while I was performing the procedure, another technique that I like to use is to temporarily flatten the needle, which will help it show up on the ultrasound screen more effectively, but then to return it to our 45-degree angle for advancement until we get our flash. The reason not to just flatten the needle the entire time is that the IV catheter is only so long, and if you take a very shallow approach, you will run out of real estate and your catheter will not be deep enough into the blood vessel. I do not want you to stress about learning these techniques, and in fact, as you go, you will find that combining them will be natural and help you find the needle tip. So if we combine the fanning and the bouncing all in one example, we'll see that the needle tip does indeed show up on the screen. Slightly advance, fan back the probe, bounce the needle, there it is. So we went in at 45 degrees, we got our flash utilizing one of the techniques we just covered, and we are ready to flatten our needle and advance it within the blood vessel. This is a still shot showing exactly what this would look like. And what you'll notice is that as I insert the needle at a 45-degree angle, I'm holding it more like a pencil. But when I flatten my needle, I prefer to grab it at its base, flatten it as much as possible so then I could advance it beneath the probe. This can also be conceptually difficult to understand, so let's go ahead and break this down and give you one more key tip. In this example, I'll ask you to use your imagination and pretend that our catheter is flashed and filled with blood here. So now that we are within the vessel, we will flatten our needle, and then we will slide the ultrasound back so that we can visualize the needle on the screen. Now for this portion of the procedure, it is crucially important to only move one hand at a time. Your left hand will be holding the probe, your right hand will be holding the needle, and only one moves at a time. Since we could see the needle on the screen, the next step is to advance the probe with our left hand. We'll see that the needle goes away on our ultrasound screen, so then we will simply advance our needle until we see the needle tip again, and we will continue to do so left hand and then right hand until essentially the IV is all the way inserted. I like to advance the IV as far as I possibly can, which will often mean that the catheter is inserted all the way into the vessel before I remove my needle. The only reason I stop this advancement is if the vessel suddenly twists, turns, dives deep, or if the needle tip gets too close to the posterior wall of the vessel. But most times I can insert the IV as far as it will go without having to remove the needle. I will also note that once you have your flash and you flatten and advance the needle, that the needle tip and point, which is the most painful aspect of IV insertion, is within the blood vessel. There are no pain sensory nerves inside of the blood vessel itself, so this portion of the procedure is relatively more comfortable for the patient than the initial IV insertion. Now, one final note here is if you ever lose the needle tip and you want to bring the probe back to see the needle, if you bring it back too far, and here we can see that the ultrasound probe is overlying the middle of the needle. On the screen, that needle can look very similarly to the needle tip. So really the only way to tell is to advance our probe again past the needle, let it go away, and slowly bring it back just until the needle comes into the screen, and now we know that we're at our needle tip. So to put this all together, let's go ahead and watch this example where we will slowly advance the probe until the needle disappears with our left hand. They will move our right hand until the needle comes into view, move our left hand until it goes away, and so on. And that's it. We've basically covered all the key techniques that I can teach you for a transverse approach for ultrasound guided IVs. But now just a few final thoughts. Number one is that the details matter. When I first learned this procedure, I thought I had a good understanding of what I was doing. I knew how to map my vessels, I knew how to insert my IV, but I made mistakes with my setup, and I made mistakes with, once I got my flash, trying to thread the catheter immediately without flattening and slowly advancing the needle. If you're feeling pretty good about the topics that we just covered, there is a lecture checklist that I'll encourage you to go over to ensure that you are familiar with all of the key concepts from this lecture. Once you are feeling comfortable with these concepts, we can have you print the procedure checklist and bring it in for your live training. Just a few references there, and a special thank you to Rob for helping me make the videos, as well as the staff including Karen, Hex, and the ambulance crew whose participation made this lecture possible. Thank you.